Okay. Good evening, everyone. I hope you can hear me.
Yes, we can, Dr. Welcome.
Thanks very much, and very sorry to keep you waiting. I know you are very busy schedules, and we are just in the middle of the week. I'm going to be discussing about management of first trimester miscarriage, and as Fred has said, very kindly made an elaborate introduction of what I do. Currently, I'm based at Aga Khan University. And it's a brief presentation, which I hope captures the succinct points that are useful for a busy clinician to put in their daily practice. So I wouldn't want to dwell on too much because we know quite a bit about miscarriage. And I would like us to recapture certain important aspects of the epidemiology and risk factors of miscarriage. But it's also important that we do recognize that perhaps miscarriage represents a health risk and not just a mere loss of a pregnancy. And we would finalize the presentation by looking at prevention strategies. So miscarriage is common. However, it is misunderstood by both men, women, and healthcare providers. And there are a number of misconceptions. For example, women may believe that they have done something wrong that could have resulted in the pregnancy loss, that there's nothing they can do to prevent the pregnancy loss happening. And there are lots of assumptions that may come across from healthcare providers. And we all know right now that couples suffer equally when a woman loses a pregnancy. So men are intricately involved in the pregnancy loss event. The consequence of this could be that there would be isolation, and most couples would prefer not to talk about it openly, and they may withdraw into a private life that then throws them into the dungeons of isolation. But more importantly is the concerns of unsympathetic routine care in healthcare systems. So you come through as though you're just going through a conveyor belt. You know, the routine history taking, you're shoved onto a bed for examination. And if you have an ultrasound scan that has been done, the breaking of the news sometimes does not capture what, you know, the sympathies that are supposed to be given to this couple. An interesting study was done in the US, which looked at expectations of women and their partners when they've suffered miscarriage. And it's useful to know that they do not want to go into, you know, their scientific jargon and the details of what miscarriage is, but they just want to understand, why did the miscarriage happen? And they really want to know what to do, perhaps to prevent a recurrence. And it bothers them that they would like to understand the chance of subsequent pregnancy being a live birth. And what we sometimes do not capture so well is how to deal with grief surrounding the loss. So this obviously doesn't encompass everything that is perhaps important to discuss with the couple. However, it outlines what is useful to focus on when you're dealing with a couple who have lost a pregnancy. We have various definitions of what a miscarriage is. And what is important is that the WHO defines miscarriage as the expulsion or extraction of a fetus weighing less than 500 grams, which is approximately 22 weeks gestation. This definition varies across the world, and it's mainly based on capability of salvaging the fetus rather than on any firm scientific basis. So in the UK, for instance, a miscarriage will be a pregnancy that is lost up to 24 weeks gestation. The ASRM, which is the American Society of Reproductive Medicine, would define this as a loss of up to 20 weeks. And the European Society of Human Reproduction and Embryology defines this as a loss of up to 22 weeks. So this variation, unfortunately, then leads into a different epidemiological classifications of miscarriage. And of course, I haven't included biochemical miscarriage in this definition, which usually will be very helpful as we discuss the prognosis with couples. Miscarriage, as we said, is common, and it tends to vary in prevalence depending on what we are discussing. So we have sporadic miscarriage, which will be miscarriage happening for the first time. And most of these definitions are based on confirmed intrauterine pregnancy or histological confirmation of pregnancy from tissue that has been evacuated from the uterus. So generally, the prevalence of one miscarriage happening will be about 10%, as you can see the range there. And the chance of miscarriage happening in the general population decreases with the number. So when we are talking about 2 or more, which will become the definition of recurrent miscarriage, then that comes to about 2%. And it's just under 1% when we say is 3 or more. So these last two are particularly useful. And you can see that if you take your definition of recurrent miscarriage as 3 or more, then you have a huge chunk of women who may actually be missed out in the definition. And perhaps there will be other consequences that you would have foretold if you had made your definition of 2 or more miscarriages. If you look at the RCOG definition of recurrent miscarriage, they talk about 3 or more, but they do include biochemical pregnancy loss. So any positive pregnancy test, including non-confirmation on ultrasound, plus those confirmed on ultrasound. However, the American definition talks about 2 or more, but excludes biochemical pregnancy loss. What are the risk factors for miscarriage? The 2 most important risk factors for miscarriage is female age and previous history. This table highlights that biological effects quite well. And we know that younger women who are age 20 and less would have slightly higher miscarriage rate. For some reason, probably when we look at the detailed pathophysiology, we could understand this a bit more, but 16% of them may suffer miscarriage. And it appears that the age which would have probably a stable miscarriage rate of about 15% on average, or 12% is 20 to 29 years. After that, the rate starts to increase such that about 15% nearly women 30 to 34 years will have miscarriage, and nearly 20% of those who are 35 to 39. But do notice that women who are 40 and above would be close to 40%, so 36.8%. And even more importantly, those who are above 45%, 2/3 of them will lose a pregnancy. This table is useful mainly because there is currently a demographic shift to when women have their first pregnancy. Of course, in this part of the world, probably a lot more women have their first baby when they are younger, but we are also seeing more women who desperately desire to have a pregnancy waiting much longer. The number of previous pregnancies does have an impact, and as I said, it has a biological gradient. So if you've had no miscarriage before, you have about 11.3% or just 10% risk that you could miscarry. If you have one previous miscarriage, then that jumps to 20%. So we will be telling them 1 in 5 may miscarry. And if you've had 2 previous miscarriages, then nearly 30% or 1 in 3 would miscarry. And if it's 3 or more, we are looking at 42%. So these numbers are very important because when you are discussing prognosis, you are looking at those 2 factors, the age and the previous history, to inform the distraught couple, about their chance. Is there a question? You're looking at this to inform the distraught couple about their chance and prognosis of a future pregnancy being successful. So it's not just throwing around numbers and telling them, it's quite common, don't worry, you may be successful. So if you break down the risk factors further, we always talk about the embryo as a significant determinant of the risk of miscarriage. So embryonic chromosomal errors may occur in up to 60% of pregnancy loss. And these tend to be the situation when you are talking about sporadic miscarriage. So do notice on the figure that aneuploidy miscarriage, which would imply that there are chromosome abnormalities on the pregnancy tissue, appear to remain quite stable in the sense that the number of miscarriage does not correlate with the abnormal pregnancy or chromosome tissue on analysis. So if you've had 2 pregnancy losses or 6 or more, they will hover around 15% aneuploidies. So the more miscarriage happen, the more likely that the pregnancy is normal. So this becomes useful as well when you are discussing about tests that you carry out. So don't be quick to, be desperate to try and get genetic testing of pregnancy tissue in a woman who has had 4 miscarriages because you think, yes, we are really going to catch something and send you across to see Charles and do a pre-implantation genetic diagnosis or screening, because majority of them become pregnancy losses that are probably due to other factors. These slides demonstrates that the most common aneuploidies or chromosome errors are usually trisomy. And I think majority of you know that trisomy 16 appears to be the one that is the commonest in the majority of pregnancy loss. And perhaps that trisomy accounts for most of them. But there are other trisomies, for example, 13, 14, 15, 16, 18, 20, 21, and 22, which also tend to feature in miscarriage. But interestingly, the risk or rate of trisomy 16 appears to be quite early in as young an age as 20. So, and that also tends to be quite stable. So when you do genetic testing or chromosome analysis in women who are younger than 35, you're more likely to pick trisomy 16 as the sole and predominant abnormality. But as they get older, there is an exponential rise in the trisomy rates, and women above the age of 35 will now show these other trisomies. Now, what is important here is that, again, if you are thinking about testing, then you have to contextualize and imagine what you are going to catch. So it might make a bit more sense in younger individuals if you're thinking about genetic testing, but perhaps it will be difficult to make sense of the clinical or diagnostic findings if you have a 35-year-old or older woman whom you are sending off for chromosome analysis. And of course, monosomy X and triploidy may also account for other chromosome errors. What are other risk factors? These are either associations or not necessarily causal, but strong risk factors for miscarriage. And it's always difficult to kind of pinpoint what is the actual cause of a miscarriage when it's already been diagnosed. But there might be endometrial defects. Endometrial defects may be linked to inherent endometrial abnormalities, or there could be systemic problems. For instance, we know the role of the trophoblasts with the interaction of the immune cells. We call them the natural killer cells. Endometrial natural killer cells are extremely unique in themselves. When you do your CD56 marking, you notice that they are not exactly the same as the peripheral blood natural killer cells. And so if you are interested in testing for such abnormalities, it will be helpful if you actually take endometrial biopsy and not peripheral blood to try and look at factors that could influence the risk of miscarriage. There might be endocrine abnormalities that can be linked directly to endometrial defects. For example, the effects of obesity or thyroid abnormalities. An area that is gaining rapid attention recently is parental risk factor, in the sense of a paternal contribution to miscarriage. And it's not just genetic abnormality, but we are talking about things like DNA fragmentation index, and to what extent that could affect the risk of miscarriage. This appears to be age dependent as well. We know men above the age of 40 will start to display abnormalities in seminal factors, and DNA fragmentation index will increase exponentially as they get older. And we see this also as a factor in fertility. Demographic risk factors, I think I've talked about female age, which is particularly important. Lifestyle risk factors, looking at smoking, alcohol consumption, obesity, they are quite significant. And we do know that advising women to reduce the risk of exposure to these risk factors, which are also modifiable, would be very, very helpful. We know about clinical risk factors, and this is mainly associated with a previous miscarriage risk, which I will not go into a lot of more detail. And there are environmental risk factors as well. There is association with, for example, exposure to chemicals, like women who work in flower farms and they are exposed to certain chemicals. We do know working night shifts. I don't know why that is the case, but it appears that if you do more night shifts, you might be at risk. I'm not suggesting that people shun to work at night, but all these other risk factors may not have a strong association, as we've seen as the age and previous history. So it is very useful and important to not look at miscarriage as a sole event of a pregnancy loss, but it's particularly helpful to also perhaps use it as a surrogate to project risk for long-term health or pregnancy complications. So, for example, antepartum hemorrhage is associated with miscarriage risk. And women who have had a miscarriage or who are bleeding in early pregnancy are prone to increased risk of placenta previa, maybe bleeding in pregnancy that is quite non-specific, and sometimes they may develop abruptio placenta. They have a higher risk of preterm pre-labor rupture membranes and preterm delivery, as well as fetal growth restriction. Of course, all these tie into increased risk of perinatal mortality and low birth weight. We can't tell exactly why these risk factors are this way, but it is perhaps linked to abnormal decidual development. And you will appreciate that most of these risk factors are the same ones that obstetricians will be discussing as abnormal placentation when it comes to trophoblast invasion. The very early stages of placental development, which rely on, the placental villi invading the vessels and ensuring that there is sufficient development of the placenta, will be linked to abnormal natural cell killer activity or abnormal decidualization. But there is perhaps a link with previous miscarriage treatment. For instance, maybe those women who've undergone repeated uterine curettage, which could damage the endometrium, may also have that these risks enhanced. Other than pregnancy problems, and especially recurrent miscarriage, could be associated with long-term health risks. And we are talking about cardiovascular disease and venous thromboembolism. Perhaps this could be linked to thrombophilias, which sometimes could be the result of recurrent miscarriage. But even without those, there appears to be increased risk of cardiovascular and thromboembolic events. The more immediate, medium-term kind of risks associated with the miscarriage will be psychological or mental health. So we know women who've had miscarriage are likely to suffer from post-traumatic stress, in about 18% of them on follow-up. And there is severe anxiety disorders, in about 13%, and even severe depression in up to 6%. So when you are encountered with a situation of dealing with a miscarriage, you won't want to just be focusing on the bleeding and managing it, but try and encompass all this in your assessment. So having put that into perspective, now we will very briefly kind of discuss the obstetric or gynae approach to managing women who have had a miscarriage. So can it be prevented? And I know this question has been nagging for many years. I think as a medical student, we didn't have an answer at that point, and we used to talk about the touch screen and all manner of things. This has been thrown out at the moment. And the debate now lingers around the use of progesterone in patients who have unexplained recurrent miscarriage. So I wouldn't necessarily be talking about, thrombophilia treatment, but when you look at these studies, which have been aggregated here, it shows that there might be some benefit from the use of progesterone. It's quite heterogeneous, and it wasn't very helpful in the debate about use of progesterone in miscarriage. For example, some of them are small numbers, single center studies, occasionally single author studies. And because of that uncertainty, other studies came up. For example, we all know the randomized trial on progesterone in women with recurrent miscarriage, which had very interesting findings. From their primary outcome, about 65% of women who had micronized vaginal progesterone given when they had a history of previous miscarriage ended up with a live birth. And those who had placebo treatment, 63.3% had a live birth. And this led to the authors to conclude that a progesterone therapy in the first trimester of pregnancy did not result in significantly higher rates of live birth among women with a history of unexplained recurrent miscarriage. But this study further looked at subgroup analysis, which had been part of the original question in women who had had more than 3 miscarriages in the past. And it appeared that perhaps giving them progesterone in the form of micronized vaginal progesterone, 400 milligrams twice daily, reduced the risk of miscarriage or improved the chance that they would end in a live birth. Even though statistically, when you look at the numbers, it appears that mathematically it doesn't make a massive difference. But when you look at the actual numbers that you need to prevent from pregnancy loss, then there might be some benefit. And so the message that comes from this trial is that if there has been a history of recurrent miscarriage with 3 or more, then there could be benefit. If there hasn't been more than 3, there might be no benefit in giving micronized progesterone. But what about those who've not had recurrent miscarriage? And we commonly see this in our clinical practice. So women with threatened miscarriage. And so the second trial is the PRISM study, which again looked at massively large numbers of women, up to 4,000, who had presented with threatened miscarriage, and they were given micronized vaginal progesterone, at this time up to 16 weeks. 72 75% of those who had progesterone had a live birth, or at least the pregnancy went beyond 34 weeks. And those in the placebo group, 72% reached 34 weeks or resulted in a live birth. Again, the conclusion of this study was that among women with bleeding in early pregnancy, progesterone therapy administered during the first trimester did not result in a significantly higher incidence of live birth than placebo. So is this confusing? Perhaps yes, but when you look at the subgroup analysis, it shows that those who had a previous pregnancy loss and presented with bleeding or threatened miscarriage appear to benefit from the use of progesterone. The biological conclusion of that would be that if you've had a previous loss and you present with bleeding, then you possibly could be tinkering on the definition of those who may end up with a recurrent pregnancy loss, which now would be 2 or more miscarriages. So in those who have had more than one and they are presented with bleeding, then there would be a benefit. If there's not been a previous history of miscarriage and a woman presents with threatened miscarriage, then there will be no benefit accrued from giving them progesterone. It's more likely that it's something that is fairly random. So I would like to just wrap up by maybe looking at how is the role of progesterone in decidualization and perhaps placental development. And these two studies might be useful for you to look at perhaps later. And molecular studies have shown that progesterone receptor polymorphisms have been introduced in the population, that these non-African Caucasian women or populations, and there is this what they're calling the Neanderthal progesterone receptor, and it affects up to 20% of women. And when you've got these polymorphisms, then it may be that there is a problem at the level of the progesterone receptor. So it is not that the progesterone is not produced in sufficient amounts. It is only that there would be those polymorphisms. And we see hormonal polymorphisms that are overcome by maybe increasing the amount of hormone levels. A good example would be when we do ovarian stimulation and women have FSH receptor polymorphisms. If you give them a small dose of FSH, they don't respond. If you give them a higher dose of FSH, then they tend to overcome that. So maybe this is one of those. The second thing is cholesterol metabolism to produce progesterone. So we know the enzymes that are involved in the pathways of cholesterol metabolism may be slightly abnormal in distribution within the trophoblast tissue. And so if you give more progesterone, it is more likely that then you don't have to rely on the cholesterol pathways to produce that, but then you supplement it and overcome that level of deficiency at the trophoblast tissue. So it has nothing to do with the ovary not producing enough progesterone, but everything has to do with how the progesterone activity happens. So I think I would like to summarize by saying we know women with previous miscarriage and bleeding may benefit from progesterone. Obviously, miscarriage is quite common in our practice, and it probably presents as one of the commonest symptoms in early pregnancy, and that endometrial defects are a major driver for higher order miscarriages, and this will be the recurrent unexplained miscarriage. Always remember that future reproductive, obstetric, and health consequences of miscarriage are real, and so research looking at preventative ways of managing these complications will be useful. I wanted to keep the presentation short so that it can be interactive and also, not bore you with a lot of science. Thank you very much.
Thank you, Dr. Muteshi. Such an elaborate presentation capturing the salient points and take-home messages. And as we started by saying, it is a common problem which will face us at one point, either in our practice or even in people seeking interventions or advice. Now, there's a certain subset of miscarriages which the second presenter will briefly touch on, and that is the missed miscarriages. And actually, the next step, I would like to invite a presenter from VIA Health. VIA Health is the pharmaceutical branch of Population Service International, and they will be discussing a product that may be useful in management of missed miscarriages. I would like to urge us that we shall have a brief session after this second presentation where Dr. will be able to take questions and respond, and also to get any addition from the audience, because it's a topic that attracts a lot of reactions, and we really want to enrich our knowledge about it. So I would like to invite Peter Moura or his colleague to take over from there. Thank you.
Okay. Thank you, Dr. Karedia. I'm trying to share my screen. I'm talking with Nelly. So to make me a co-host, so that let her sort it out. A minute. No, I think I can. You can see my screen now.
Yes, proceed, please. Thank you.
Okay, so I'll try also to be as brief as possible. So as you said, we are VIA Health, and who we are is that VIA Health, we are a private limited company wholly owned by Population Service International, PSI, and we seek to sustainably meet the needs of women along sexual reproductive journey. So from menses to menopause, we want to have information, service, and products that meet the women needs in their sexual reproductive journey. So our vision is to allow women to access trusted information, product, and service with ease. And how we are doing that is that when you visit VIA Health website, you can see that we have discussion around various topics. And I want to tell you, we are also going to come back to you as the source of trusted information, and we can partner in making sure that women access trusted information at their fingertips. The products and services that we provide, our products are available in most pharmacy, and just to ease the access, the products are also available with the online pharmacies like MyDawa. So we have a goal to improve women's reproductive health and sexual wellness journey. by expanding the choices and addressing the barriers that they have in accessing the product and services. So as Dr. Fred have highlighted, what we have is we have a product that addresses the need whereby you have a missed abortion, where you might need a uterine evacuation. So the product is Medabon. So when you look at the various methods of uterine evacuation, we are talking about the vacuum or manual, vacuum aspiration, electric or manual, and also we are looking at the medical abortion. So when you talk about 2OP, we refer the ending of the pregnancy by taking medication rather than the surgical intervention. So when you are managing miscarriage, we have the medical method. So with the medical method, we have the mifepristone in combination with the misoprostol or the misoprostol only regimen. So we have the combination of the 200 milligrams of mifepristone and combined with 4 misoprostol of 200 mcg each. So when you're talking about the misoprostol only, when you talk about misoprostol only, we have the challenges that we have with using the misoprostol only. However, we are talking about the misoprostol only taking the use of the medication takes longer and have lower success rate. And that's why we have a need hereby to add a pre-treatment with the mifepristone to increase the success rate, or also the success rate when you are managing miscarriages. So when you talk about misoprostol mechanism of action as a prostaglandin, it causes the rhythmic uterine contractions. The uterine contraction causes the detachment of the product of conception and the expulsion. So that is why when we look at the efficacy of misoprostol, we are talking about a success rate of 85 to 88% when used correctly. And in other studies, we are talking about a success rate of 89 to 92%, depending on the gestation. So that's the misoprostol only regimen. So then there's the common possible complications that come with the use of misoprostol only. And key among them, I can say, is incomplete and failed abortion, which have to be treated with aspiration. So we're talking about the retained product of conception. And due to all these challenges that we have the misoprostol only regimen, that's why VIA Health is proud to introduce Medabon, which is a prescription only medication for use in miscarriages of less than 12 weeks, where we have retained product of conception. So why the Medabon combi pack? So we have packed the mifepristone together with the misoprostol to help. And one of the challenges we have is the misuse of the misoprostol. So by repackaging, we are addressing the regulatory issue. Then the ease of use. So both for the provider and for the clients who are using the combi pack, is easy to use when it's packed together as mifepristone and miso. So let's talk a bit about the route of administration. So we have one mifepristone tablet. This one is taken orally. So we take the mifepristone orally. Then after 24 to 48 hours, you take the misoprostol either buccally, sublingually, or vaginally. So we have the buccal route, where you take the 2 pills in each cheek, between the cheek and the gum, and let them remain there for 30 minutes, and then you swallow whatever remains. The same with sublingual. So you can take the 4 pills under the tongue and swallow whatever remains one thing to note about this route is that with the sublingual route of administration, there is the increased side effect of fever and chills as opposed to a vaginal method. So the other way you can take the misoprostol is to do the vaginal route. I'll not go into details. Yes. So in summary, we are talking about when you're using the combination of mifepristone and miso, you take one mifepristone, 200 milligrams orally, then wait for 24 to 48 hours. After 24 hours, it depends on the convenience of the client. So that's they can choose any time after 24 hours to use the misoprostol regimen. So a bit about the mechanism of action of mifepristone. So mifepristone initiates the breakdown of the endometrium. And when you look at step one, when you initiate the breakdown of the endometrium, it leads to detachment of the embryo. So that by the time you are giving the misoprostol only, the product of conception will have detached from the endometrium. So the other thing is that mifepristone does it sensitizes the endometrium to the action of the misoprostol. So you are born to get better outcomes when you're using the combination of mifepristone and misoprostol as opposed to using the misoprostol only regimen. So the other advantage is that as opposed to the surgical way, there is acceptability by the client since it's less invasive and it feels more natural, more private and discreet, and she feels more comfortable and in control. So even for the providers, when you're using the combination of mifepristone and miso, is that it's quicker to administer, it's more effective and less invasive as compared to the MVM. So when you talk about the combination of mifepristone and misoprostol, the other thing that we can talk about is its effectiveness. It's 95 to 98% effective as opposed to using the misoprostol only. Excuse me. So let's talk a bit about the contraindication. So the combi pack is contraindicated in cases of suspecting ectopic pregnancy, in cases of chronic adrenal failure, in cases of where the patient might be allergic to mifepristone and misoprostol. So I think unless you have any question, that's the end of our presentation. We have Medabon available in various pharmacies, especially in Malibus and Lila and its branches. And you can always reach out to us. I'm Peter Moura, and I have my colleague, Teddy Oganda. I think that's all from my side.
Thank you, Peter, for keeping it brief. And probably you would have mentioned what is the pricing, because that's one of the consideration. Now that you mentioned that medical evacuation is cheaper than surgical evacuation,
So
you can mention that in a minute, then we respond. There are quite a number of questions. I hope Dr. will be able to skim through. Thank you.
So the pricing of Medabon is 1,140. So that's the pricing that the patient will get it from, let's say 1,200 to 1,500 from the pharmacies.
Thank you, sir. Dr. Muteshi, there are quite a number of questions. Maybe I'll read the first three. You can briefly comment about. You can see them on the chat function of the meeting.
Yes, please.
So the first question is from Francis Were. Dr. Francis Were is asking whether there is, what is your take on the use of amino acids like tivotine? And tivotine is is an arginine something in the prevention of pregnancy loss. The second question is from Dr. Evelyn Okello, is the use of aspirin or heparin in patients with recurrent pregnancy loss. And the last question, the third question from Dr. Agnes Gashoki, give us some insight in the use of junior aspirin. I think it's the same as what I've just read. Maybe you can take those two.
Thank you. Very important question. So I think I'm not aware of evidence around use of amino acids in the treatment or prevention of miscarriage. We do know that it's useful for women who are trying for pregnancy or in the first trimester to be taking folic acid. Currently, there are so many formulations on the market, and a lot of them have a combination of amino acids and all manner of things. As far as I am aware, the additional nutrients and supplements may not necessarily have a significant role in preventing miscarriage. We all know that folic acid is extremely useful in prevention of neurotube defects, and that anyone who is trying for pregnancy should be on it. The role of aspirin and heparin is not disputed, and I think I did mention that my presentation focused mainly on unexplained recurrent miscarriage. So when you work up a patient who has recurrent miscarriage, the majority of them may not have a defined or definite cause. And we do know that probably genetic or chromosome problems account for perhaps less than 2%. And there would be a good chunk, maybe 15 to even 20%, who may have antiphospholipid syndrome. And if they do have antiphospholipid syndrome, then there is pretty good evidence that use of aspirin and heparin will reduce the risk of miscarriage. So live birth rates would normally be in the range of about 65% compared to those who do not take these medications. And their live birth rates will be in the 40% ranges. I think it's good to also mention how in practice this is actually given, because sometimes it causes a little bit of confusion. So usually you would advise women to start taking aspirin as soon as they test positive for pregnancy, before an ultrasound scan is done around 6 weeks. And if it demonstrates that they've got an intrauterine pregnancy that is viable, then you will start them on heparin. I think that answers the two questions, perhaps.
Yes, there are two other questions.
Yes, so I can see a question on use of intralipids and hydroxychloroquine. I didn't realize that this is extended its use beyond coronavirus treatment. So I think intralipids are a very interesting component. And one of the frustrations we've had in early pregnancy management is trying to understand the pathophysiology of recurrent miscarriage. It is becoming a bit more clearer that maybe decidulization is the problem and impaired placentation, but exactly why we haven't quite figured out. So the role of natural killer cells, for example, which are immune modulators, they do help in angiogenesis and placental invasion, but they are not the peripheral type natural killer cells. So it's useful to know that the peripheral type natural killer cells are immune defense cells, and they are extremely different phenotypically and in function compared to uterine natural killer cells, which are pregnancy permissive. So they are very useful for angiogenesis, and they help in placental formation. So intralipids, which were initially touted as a possible treatment for increased peripheral blood natural killer cells, do not have a role in the management of recurrent miscarriage. And in fact, there may be certain problems that may come with them. So currently, we don't use them. I'm also not aware that hydrochloroquine would have a role. There's a question. So very occasionally, obviously, we get patients who might have autoimmune conditions, and some of them, if they do have positive antiphospholipid antibodies, then they may benefit from use of aspirin and heparin. They may be taking hydroxychloroquine for their condition, but it does not help in reducing the risk of miscarriage. So if they do have an autoimmune condition that requires the use of hydroxychloroquine, then that is helpful. And if they do not have positive antiphospholipid antibodies, then they may not benefit from aspirin or heparin. So that will not help in reducing miscarriage rates. I hope it helps. Vitamin D has been shown to have a role in early pregnancy development. And there are interesting studies that were published probably 5 years now or so, which showed that in the Caucasian population, women with vitamin D deficiency had an increased risk of miscarriage before 12 weeks. So it is quite sensible that you would want to correct deficiency in vitamin D in someone who has previous pregnancy loss. Maybe in that way, when you're looking at modifiable risks, which may include, reducing weight, stopping smoking, and all that, it will be bundled together. I think I wouldn't want to comment more on mifepristone and misoprostol because we've had a presentation on that. And I think Maurice asks about for patients with a history of recurrent pregnancy loss and are undergoing ART, does the history alter live birth rates after ART? I'm not necessarily aware that this might be the case, but obviously a pregnancy history in patients who are going through IVF is considered as a positive prognostic marker. But it's useful to know that ART is not an alternative to treating miscarriage. So these are patients who are struggling to keep a pregnancy. They are not struggling to get pregnant. So don't send them across to try IVF because they've had a recurrent pregnancy loss. However, if there is a genuine indication for ART, then they may go through that treatment. I think I can see a question on injectable progesterone. So I think if you remember well, hydroxyprogesterone has recently been withdrawn from the use in the prevention of preterm birth in the US by FDA. I am not aware that injectable progesterone works any better than the micronized progesterone. There are some studies which have indicated that maybe dihydroxyprogesterone, which is dufastone, could be used. If you look at the table that I shared, the study numbers are quite small. Some of them are single center, and there is a little bit of concern about dufastone in terms of fetal risks, particularly cardiac anomalies. So I think the pendulum in that sense keeps swinging back and forth, but I think we now know that probably micronized progesterone may be useful. What's the dose of aspirin? We use 75 milligrams, so it's not as that is used for prevention of preeclampsia in women who are the previous who are at risk of preeclampsia. In IVF patients, is it always necessary to do estrogen priming prior to starting your luteal phase support? I'm not sure I understand that question well, but in patients who are undergoing frozen embryo replacement, then they will require estrogen prior to use of progesterone. However, addition of estrogen to a normal cycle of IVF may not necessarily be helpful. I don't think I want to bore the audience with the nuances of IVF, but if you're doing a fresh cycle with what we call the antagonist protocol, and you trigger, you do your trigger using the agonist, then there might be a role of giving estrogen and progesterone in the luteal phase, but not priming before the cycle starts. When would you advise the patient on getting a surrogate? I'm assuming that those who are quite frustrated and they would like to possibly try something different. I think the indications generally of surrogacy treatment would be that it is not safe to be pregnant or the womb is unable to carry the pregnancy. If you look at the studies, looking at the prognosis of a live birth in women who've had recurrent miscarriage, then it is more likely that if they kept attempting, they might succeed. But also remember that as the number of pregnancy losses increases, then their chance of getting pregnant decreases. But it's also possible that they will be getting older. So if they are older, their odds of getting pregnant using a surrogate will be much less. But overall, we usually would say that you have a higher chance of getting pregnant naturally than you do if you do IVF. So for any indication, if IVF is an alternative, it still carries a much lower chance of success compared to those who are trying naturally. So they may still be in a better position to conceive naturally than to think surrogacy will help. Fred, I think that could be the end of the questions, unless there is one that I've missed out.
I think we have exhausted the question in the chat box. Skimming through the participants, I'm not seeing any person who has raised their hand. So we'll come to the end of the meeting. First, to thank you for such an elaborate presentation. And as you can see, it's a topic that attracts a lot of interest, because in our practice, we meet clients with such problems every now and then. And perhaps we might have to have a more detailed discussion, either in this platform or in another forum, whereby we're able to exchange experiences and learn from experts like yourself, and also get to find out a bit more on how to manage this problem of recurrent pregnancy losses in the first trimester. I would like to also to thank the participants. We've had quite good participation. And we look forward to the next series where we highlight some of these issues and educate each other. On behalf of Nairobi branch COGS, I would like to thank you for attending the CME. We are CPD accredited. So as soon as we process those who are eligible in terms of understand there are people who need the points for purposes of complying with the medical council requirement for renewal of licenses, we shall process and communicate in due course. from me, it's a good night to everyone, and thank you. God bless you. Asanteni sana.
Thanks very much and good night.
Thank you. Good night.
Thank you.